So currently, the standard of care for young CLL patients who are fit is Fludarabine, Cyclophosphamide, Rituximab, FCR. And this standard of care has been recently challenged by the novel agents, the chemo-free agents, and notably ibrutinib. So right now there is a consensus on who is not FCR eligible, which are the patients who have an alteration of TP53, whether 17p deletion or TP53 mutations. These patients do very poorly with chemotherapy, so they are eligible for ibrutinib on frontline. For the other patients, the ones who can receive chemo, from the recent trials, there is evidence that for the IGHV mutated patients who currently do very well with chemotherapy, it's a consensus, a relative consensus, to keep them on chemo because they can expect a very long PFS. Now, for the patients who have unmutated IGHV, we know that the PFS with immunochemo is not so good, and these patients would benefit, and that has been shown recently in trials, from ibrutinib or from a combination of chemo and ibrutinib. But unfortunately, in many countries, there is no availability of ibrutinib for this indication. So right now there is a big challenge on stratify the patients and try to find the best combination for these patients in frontline. These challenges, there are several problems. I think that one of the main problems is the reimbursement of the drugs in many European countries. That's the main issue. So even if ibrutinib has been shown to be superior to FCR for unmutated IGHV patients, right now we cannot, for example, in France, we cannot use it yet. And so we are hoping for move forward because the indication is really sound. The other challenge is to have enough clinical trials to find out the best combination, and also to find out how to combine these drugs in order to be able to have a definite treatment and not a long-term treatment that you don't stop. So these are I think the two challenges to move forward right now.